Good evening, everybody, and welcome to this evening's Twilight Online Cannabis Medicines Part 1, Current Evidence and Availability. My name is Samantha, and I am your host for this evening. Before we get started, I'd like to make a quick acknowledgement of country. We recognise the traditional custodians of the land and sea on which we live and work, and we pay our respects to elders past and present. Okay, I'd like to introduce our presenters for this evening, Dr. Harry Nespolin and Dr. Jan Fizzle. Harry is the current chair of Sydney North PHN and principal of 2 general practices in Sydney. Harry is also a fellow of the RACGP and a quality assurance examiner for the OSCE Fellowship exam and has been doing that for the last 10 years. Jan is a public health physician working as a medical advisor in the Office of the Chief Health Officer at the New South Wales Ministry of Health. She has been working on facilitating the New South Wales clinical trials program for medicinal cannabis and cannabis-derived products and assisting in cannabis therapeutics policy development in New South Wales. So welcome, Harry and Jan.
Thank you.
I will hand over to Harry now to take you through the learning outcomes for this evening.
Welcome everyone. My name is Harry Nespolin. I will be facilitating tonight's webinar. And I just quickly want to go through the learning outcomes that we're trying to achieve. By the end of the online CBD activity, you should be able to identify the difference between medicinal cannabis and illicit cannabis products, explain how cannabis medicines work, list the types of cannabis medicines available, and explain the existing evidence for cannabis medicines use for specific health conditions and the importance of evidence-informed prescribing. We will be addressing questions throughout the presentation, throughout Jan's presentation, but we will try and group the questions up so that we're not disturbing her presentation too much. Now I'd like to hand over to Jan.
So good evening, everyone. It's lovely to see so many people online. My name's Jan, and I'm here to help hopefully provide some interesting information for you. So going through our presentation tonight, I'm going to first of all talk about what makes a medicine a medicine, some of the things that we know about cannabis as a medicine, and then talking about 2 of the most important cannabinoids available in medicines in Australia at the moment, and that's delta-9 THC, including some of its uses and adverse events, cannabidiol, often abbreviated to CBD, and how it's being used in some of the adverse events, the available combinations of THC and cannabidiol, and the evidence for use in certain conditions from some of the reviews that the Therapeutics Goods Administration commissioned last year. So talking about cannabis as a medicine. So we've got this thing where we regulate therapeutic goods. We know that therapeutics have a known composition. They've got known likely effects, and we generally know what their likely side effects are. We've usually got a product information and quite a bit of information that we can go to look up and understand what's going to happen when we use a certain dose in a certain patient. We generally know what the likely activity is in the body, so that we know how long it's going to be active for that patient, and we usually know how long it's going to take for that product to leave the body. Now, cannabis as a plant is a fantastically complex plant. There's over 100 cannabinoids, which are particular chemicals. We know that when we heat a cannabis plant, we convert some of the non-psychoactive cannabinoids from their acidic form to their active form. We know that there's also other potentially active ingredients in cannabis plants. And we also know that even if we've got exactly a clone plant, depending on where we plant it, when we harvest it, the amount of light that plant's exposed to, where the product's grown, including, I think it's latitude, you're going to have a different cannabinoid content from exactly the same clone of a plant. We also know that in Australia, when the police seize cannabis being used illicitly, most of the cannabis being seized in Australia has got really high THC content comparatively, and not a lot of the cannabidiol. So if a patient is using a product that they've grown themselves from seeds they've obtained in Australia, chances are they're using a high THC, low cannabidiol product. So when we look at the black market products that people are using in Australia, Or look at some of the foods that are available overseas, and your patients might talk to you about brand names like Medicinal and so on. We know that overseas and in Australia, the cannabis plant's really, really good at cleaning up paddocks. It sucks up heavy metals. People use a lot of pesticides, but also once we've cut the cannabis, it's also quite a good medium for fungal growth. And so there's often significant contamination from black market products. When people try and turn black market cannabis into a tincture, there's lots of different ways. You only have to Google on YouTube and you can find 10 different ways to make yourself a cannabis medicine if you're so inclined. But that means that we've got no standardization of the end product. So a person might say, well, I had a gram of cannabis that I did something with. How much active THC they've got at the end of that process is going to vary significantly. So people get different doses with each batch they make. Overseas, people in some countries in Europe have cannabinoids available in their food products. And we know that some of the companies that do food testing and are trying to market their products as, just about medicine therapeutics, even their own testing, those companies show that there's significant batch-to-batch variability in the cannabinoid content. The US Food and Drugs Administration has done some testing of products being sold in America as foods. Some of them being sold as having high cannabinoid content actually have no cannabinoid content. Some of them have very different cannabinoid content to what's on the label. And we know that even some food-grade products in some countries actually do contain THC, even though theoretically you'd think that they wouldn't, because usually one of the regulations about having a food is that they're THC-free. So when we look at cannabis as a medicine, we have had a history of using cannabis and cannabis extracts as a medicine, and it's quite interesting. Even when we look back in history and we look at some of the articles written in the 19th century about cannabis, the doctors even then were complaining about the batch-to-batch variability of medicines because they were making it from a plant, and at that time they didn't have gas chromatography. So, even doctors for 200, 300 years have been using it as a medicine, but even so, it's been difficult to get a standardized product. Towards the end of the late 19th century, people who were concerned about the intoxicant qualities of cannabis started to see the medicines being moved into poison schedules. So Western Australia had cannabis or Indian hemp put into its poison schedule in 1899, for example. And we've seen increased regulation as people are more concerned about the intoxicant effect rather than their availability as a clinical tool. However, in Israel, there was continued research throughout the 20th century, and that led to us being able to recognise some of the endogenous compounds that our own bodies produce, and that gives us a clue as to how some of these cannabis medicines may actually work on us. So we get to the endocannabinoid system, and this is a busy slide, and I'm really sorry about that. But basically, the really exciting thing about cannabinoids are they work all over our bodies. But it depends on the dose. It depends on that person's particular metabolism as to what effect that they're actually going to have. But you've got two major ones that people talk about, which is anandamide and 2-AG. And basically, they can really affect how your neurotransmitters work. They moderate things like your cyclooxygenase system. They can have immunomodulatory effects. They can help with inflammation because they work on your cyclooxygenase. They can help stimulate appetite. They have things to do with your homeostasis, so there's interest in them as, potential medicines for diabetes. There's a whole lot of really, really interesting things that these molecules do, but we're still at the very infancy of really understanding how they do this in a standardized fashion.
And so the cannabinoids attach themselves at different affinities to the different receptors?
Yeah. So, for example, THC binds to your CB1 and your CB2 receptors, whereas cannabidiol tends to block uptake at your CB1 and CB2 receptors and tends to moderate things through other channels. I'd really encourage people who are particularly interested in the pharmacology of them to do more reading of it, because it's really complex. And a lot of it is still, you know, as I say, it gets published every day. Something new that we've discovered works in a, you know, a rat model of a disease, works in how we understand the receptors. So it's complex, it's not simple, and however, like a lot of things in medicine, just the same as most of us can't explain exactly how paracetamol works, we tend to be able to move on. So we do have registered medicines. So we do have one registered medicine in Australia, which is nabiximols, which is a 1-to-1 ratio of tetrahydrocannabinol and cannabidiol. Its trade name is Sativex. It's on the Australian Register of Therapeutic Goods. It's marketed here in Australia. It's not available on the Pharmaceutical Benefit Scheme. Its registered indication is spasticity and multiple sclerosis. And a lot of the evidence that we'll talk about later has actually been generated from clinical trials using this particular drug. Overseas, there are medicines registered. Dronabinol and nabilone are THC-only products. And just recently, there's been a recommendation to the FDA that a cannabidiol in sesame oil product manufactured by a pharmaceutical company that's been in clinical trials and is being used here in New South Wales for paediatric epilepsy. That's been recommended for registration but isn't registered yet. So we have imported cannabis medicines. So unlike a lot of other drugs where when they're unregistered in Australia, usually they're imported on a case-by-case basis, the Commonwealth government's decided to allow shipments of cannabis medicines into Australia. So we have no homegrown products as of yet. They're largely coming from Canada, where they're being held to good manufacturing standards. So there's two standards that has to happen. One is the good agricultural practice standard, which is about growing things that aren't contaminated with heavy metals and pesticides. And the next one is the good manufacturing practice standard, which is about making things to pharmaceutical quality so that you've got some consistency between your products, so that if your patient gets prescribed a medicine, that, you know, for every batch of that medicine, you should be expecting the same sort of effects and side effects, unlike some of the black market and artisanal products that people are using at the moment. However, we don't have a lot of phase 1 data, so there's not a lot of safety data for some of these products. But also we don't know, you know, in hundreds of healthy people how a lot of these products are absorbed. And we do know that they're variably absorbed. Some people are really good at metabolizing cannabinoids. Some people are slower metabolizers. We don't know all the metabolism because we know that, for example, depending on which carrier oil a cannabinoid's in, they'll be absorbed and metabolized at different rates. And again, they get excreted at different rates. The really important thing is to understand that whilst they're used a lot in Canada, they haven't actually been tested for safety or efficacy. And we do know, however, that some of these products, if you're trying to look for which one of these might I look for, some of the products are used in clinical trials in Australia and overseas. So at least they've gone through a Human Research Ethics Committee scrutiny before they start being used. And so that gives you some hope that they've got, you know, at least had something go over them with a ruler.
And do we have any idea how long it will be before there's an Australian product?
Look, they're in development at the moment, and you'll probably read on the share market reports before you read it in the medical reports, to be honest. And that's how we're finding a lot of information about the cannabis industry in Australia. So one of the things that we often hear about is how much the imported cannabis medicine cost. Unlike a lot of other medicines where you're paying for a lot of the research and development, here a lot of the medicines are actually priced at how much cannabinoid per dose you're getting. So basically, if you've got a 10 milligram dose, you're usually paying about 30 cents per milligram for THC containing medicines. So your patient, if they're on a 10 milligram a day dose, would be paying about $3 a day. If, however, they had a THC to CBD medicine where they were using 10 milligrams to 10 milligrams a day, it would be about $6 a day. And for cannabidiol-only medicines, these are the ones that you're often seeing in the press. Kids using cannabidiol for their epilepsy are often using 20 milligrams per kilo. So we wind up at costs of around about $120 a day, and that's where the real affordability argument comes in. If we look at black market products, in New South Wales, we see hydroponic cannabis costing about $10 to $50 a gram. In Canada, we see patients using about 2 grams daily on average, so that would be about $20 of black market product a day. And I know lots of people can grow their own and do different things, but you're not necessarily doing your patient a favour by sending them down to the pub, because the cost may not be as different as you think. It depends a lot on the dose, and we see very different doses for what we're using the cannabis medicines for.
So this is likely to limit its appeal to a lot of people.
Well, I think particularly if a patient's really interested in it, if they think it's going to cost so much that they don't want to talk to you about it, if you can actually reassure them, if you're on a lower dose, actually it's possibly not going to cost you that much compared to what the black market is, that's a good conversation to have, because the patient at least be having something that's safe and quality controlled. If it is a conversation about a child with paediatric epilepsy, like a lot of the really expensive drugs that are highly specialised drugs, they're usually prescribed in our public hospital system, and we have mechanisms to do that. And so that's about sending people to the appropriate, highly specialised centre that deal with high-cost drugs all the time. So we can have a look at some of the components of our cannabis medicines that are available in Australia. So the first cannabinoid I'll talk about is delta-9 tetrahydrocannabinol. Now, one of the myths is, of course, that medicinal cannabis can't get you high, but actually using delta-9 tetrahydrocannabinol is actually it's a very legitimate therapeutic. So trying to say, medicinal cannabis won't get you high and you shouldn't use this product is probably not a good message, because this is actually a product that's quite well studied. It's responsible for a lot of the psychoactive effects of cannabis. We know that it reduces nausea and vomiting, and that's in fact its registered indication in the United States and Canada. Dronabinol is a synthetic THC product, and that's its registered indication. We know that in animal models of pain, it can help reduce pain, but that hasn't necessarily translated through to the human clinical trials. A lot of what I'm talking about tonight is, if you're a mouse or a rat, cannabis is an excellent drug for what ails you. But unfortunately, like a lot of things that we see working really well in mouse models, when we move it to human translation, it's not always as effective. We think it can improve appetite. We certainly know that, there's the legendary munchies effect. However, some clinical trials have shown it to be more equivocal. And the really interesting thing about it is that in some doses it's anticonvulsant, and in some doses it's proconvulsant, and you also sometimes don't know until a person's actually had it. We usually see oral doses starting at about 2.5 milligrams twice a day, and the usual maximum is about 30 milligrams a day, because after about 30 milligrams a day, most of the product information from the drugs registered overseas, that's when you really start seeing the psychoactive effects well outweigh any clinical benefit from anything else. If we look at the adverse effects of using a THC product, and for this slide I've used the product information for one of the registered products overseas. We see asthenia, which is a general weakness and malaise. I had to go away and look that one up because it wasn't a word I use often in my clinical practice or in my public health medicine practice. We do see palpitations, tachycardia, vasodilation and facial flush, none of which would be, hugely concerned. Interestingly, paradoxically, it can also cause nausea and vomiting. Now, I'm not going to talk about chronic cannabis dependence and some of those other issues that come with cyclical vomiting with that, but, it can actually contribute to nausea and vomiting. And with the CNS, it can also cause dizziness, euphoria, and of course, depending on who you are, that euphoria is either a benefit or a negative. It can cause a paranoid reaction in some people. It causes people to feel sleepy. People find that they have trouble organising their thoughts. Some people feel nervous and anxious when they take it, confused, feeling out of body and hallucinating. So if you look at the ones for the STAR, they're not actually uncommon. If you treat 100 patients, you'll have 3 patients with that, as long as you don't go too high with your dosage. When we look at cannabidiol, this is the one that's a particularly interesting molecule, because we're still learning how to use it and what the likely side effects are, and even what the long-term effects are going to be of this. One of the really interesting things about cannabidiol is that it seems to modify some of the psychoactive effects of THC when it's co-administered. Doesn't completely ameliorate them though, so we can't say if we give a 1-to-1 ratio of cannabidiol and THC that somebody won't have a bad psychoactive effect from the THC. But we do have some hope that people will have less problem. We've seen it become a sedative at around 300 milligrams a day. We do, however, know, and this is really important when people are prescribing it, that it's a potent inhibitor of lots of enzymes in the P450 So any of those drugs that are completely notorious for it, welcome to cannabidiol. It'll have a nice interaction with them. In refractory pediatric epilepsy syndromes, they're using quite large doses, around 15 to 20 milligrams per kilogram a day. We actually don't have a lot of evidence. So some of the preparations that you'll see imported, say, have a 50 milligram capsule. Now, we don't have a lot of evidence for cannabidiol alone having a particular clinical effect at low doses. There's lots of theoretical things it might do. It seems to be an antioxidant. It seems to be an anti-inflammatory. It seems to be neuroprotective. In some of its immunomodulatory effects, one of the interesting things is, are we getting some of the effects of cannabidiol in pediatric epilepsy because, they respond to prednisone? Is it the immunomodulation of the cannabidiol that's actually helping control some of those seizure disorders in those kiddies? So it's not, however, completely side effect free. When we look at the results from the clinical trials for pediatric epilepsy, we can see that they are documenting common adverse effects, and they include the kids getting diarrhea, they become sleepy, some of them can run an unexpected temperature for no good reason. Their appetite can be decreased, which, you can understand if it's opposing some of the effects of THC. THC stimulates appetite. Cannabidiol opposing those effects may decrease the appetite. Some of the kids vomit. And what we do see in pediatric epilepsy is we're seeing really high levels of some of the anti-epileptics. And so they're getting high levels of refinamide, pyramate, clobazam. And so then when you have a look at other drugs that your patients might be using, for example, warfarin, metoprolol, amitriptyline, paroxetine, some NSAIDs, you might find that they get increased serum levels. So it's really important that if, for whatever reason, a patient's doing something with a cannabinoid, that you've got an open and honest relationship with them, because otherwise if suddenly they're having postural hypertension and really sleepy, it might be their amitriptyline that they're also on for their pain rather than the cannabinoid itself. It's not that the cannabinoid's doing it, it might be their drug-drug interaction, so it might be about if they're getting a benefit from the cannabinoid dropping back on some of their other medications.
So we've had 2 questions. The first question is, what are the effect of the cannabinoids and alcohol? And secondly, can you drive while you're taking them?
Okay, so we tend to see an additive effect of cannabinoids and alcohol as far as adverse events go. So They tend to potentiate the intoxicating effect of THC. It hasn't had a lot of studies that I'm aware of, cannabidiol and alcohol, so I can't comment on that, because believe it or not, people with pediatric epilepsy are not heavy drinkers largely. So that's where most of the clinical trial data has come from, and there hasn't been a lot of systematic collection of adverse event data and drug-drug interactions with alcohol and cannabidiol, because the number of adults who are taking cannabidiol alone are small in the reported literature. As far as the THC, alcohol certainly potentiates the intoxicating effects of THC. Now with driving, we pulled together an expert panel in New South Wales to talk about driving, because is there a safe time to drive, how long to drive after? And unlike alcohol, where we see a fairly linear response between blood alcohol goes up, impairment goes up, cannabinoids are really interesting. Some people have significant impairment at a certain blood level. Other people have got zero impairment. People who've got heavy use will have cannabinoids washing around their system for longer times than people who are using low doses. So the answer is we have no safe answer. What we do know is that there are good driving studies with people using THC, which says that they have trouble staying in their lane because they get this inattention thing happening. We do know that generally it's an intoxicant, so people's judgment about making decisions about, oops, I've got to do something right now, and are there. So, and we also know that authorities overseas, so Canada says if you're on a THC product, don't drive. Israel says if you're on a THC product, don't drive. The product information for Sativex says if you have spasms from multiple sclerosis and you're using Sativex, you probably shouldn't be driving. So our advice that we were given at the Ministry of Health from our expert group was generally people will be impaired, and as such, they probably shouldn't be driving. And it's also not a defence under the Drugs Misuse and Trafficking Act to have had a cannabinoid prescribed to say that you can, I've been prescribed this, I'm right to drive. It's not a defence under that act. And at the moment, we don't have the collective evidence to be able to go to our colleagues in justice and say we need an exemption for this group of people. Because one of the levels of impairment, which I think is like 5 nanograms per mil in blood of THC, is also crosses the therapeutic boundary of what you actually want somebody to be achieving for some of the therapeutic effects. So by definition, if you've got a therapeutic effect of the drug, for some people, you also have impairment. So we're not at the stage where we can go to our colleagues and make a clear case for why it shouldn't be an offence to drive with THC in your system.
So currently in New South Wales,
the advice,
don't drive. If you get picked up, you're in trouble.
Yep. And if you ask me how long after a patient's been administered THC can they drive for, at the moment, the advice from the guys who are doing the chemotherapy-induced nausea and vomiting trial. So those patients are only having it for a very limited time because they're only going to be feeling sick from their chemotherapy for a window of time. And I think they're sort of saying 48 to 72 hours. But that, again, is assuming those patients are not regular users of cannabis. They're not, they're de novo. But it's not 12 hours like you might see on the RTA website. They're being quite conservative with their advice for their patients. And for a patient being administered it every day, we don't have a safe level to say, yes, you can drive.
And that's because THC's got quite a long half-life, doesn't it?
Absolutely, and it's variable. And the saliva test does only test for THC. It's not testing for metabolites, but to get a blood level going and keep it going, particularly if you're an oral product, you're probably going to cross that impairment boundary. And so that's the really hard part. It's a bit like you're assessing all your patients that you're prescribing potentially sedating medications for. And again, if you've got a patient that's got such a severe condition that they might need the THC, that condition in itself might be the impairment that suggests they shouldn't be driving. So again, it's about assessing your patient with the impairment. And so if they've got a general impairment that you're treating, really have a consideration about what am I treating? Has this person got such terrible pain that they're distracted anyway, that they probably shouldn't be driving? Has the person got epilepsy, that they probably shouldn't be driving? Cannabidiol in and of itself won't get picked up on a saliva test, but because of all those drug-drug interactions and the fact that it's usually being used for refractory epilepsy, the person probably shouldn't be driving. So the last drug I'm going to be talking about is nabiximols, and that's that registered product Sativex. It's registered in Australia for MS spasticity. Per spray, there's 2.7 milligrams of THC and 2.5 milligrams of cannabidiol per spray. You'll notice that I'm not abbreviating my cannabinoids to CBD and so on that you might have heard in some other presentations, and that's because we're trying to encourage good prescribing practice, because what we see is people either not being familiar with the abbreviations and trying to prescribe a cannabinoid that's actually not commercially available because they've got mixed up. One of the classic sayings is it's cannabinoid Scrabble, CBN, CBG, CBD, and so on. So we're really encouraging doctors when they're prescribing it. THC is a fairly, well-known abbreviation for delta-9 tetrahydrocannabinol, but we'd really encourage people, as more cannabinoids become commercially available, please spell out your cannabinoids when you're writing a prescription. This one's administered as an oromucosal spray. You don't need to go to the TGA to get off-label use approval, just like you don't need to go to TGA to be able to prescribe amitriptyline off-label, for example. It does need state authorisation as it's a controlled drug. And it's been investigated for use in chemotherapy-induced nausea and vomiting, where it was promising, but that study had 16 patients in it. There's been huge studies done for it in chronic cancer pain, and across the different studies, it was a non-significant improvement in pain. So there was a tendency towards an improvement, but it wasn't significant, and whether it was clinically significant is something else to debate. But what they do seem to see is an improvement in quality of life in these chronic cancer pain patients, which, if you're thinking about what are you really after in a person that you're looking after in palliative care, that's important. There's been a small pilot study in rheumatoid arthritis, and that's tended towards disease severity improvement and pain improvement, but it doesn't suggest that tomorrow everyone with rheumatoid arthritis should be prescribed nabiximols. And there's also been recent clinical trials in New South Wales around mitigating cannabis withdrawal syndrome. So it's got a really interesting role in perhaps mitigating cannabis withdrawal syndrome. And I think overseas it's being investigated for some of the narcotic withdrawal syndromes. So I've just mentioned some of the other cannabinoids, and as I said at the beginning, there's over 100 cannabinoids in the cannabis plant, and they're really interesting. The really important thing to understand is by the time that they're usually in a medicine, they're in a very different concentration to what you would normally see in a cannabis plant, and that's because usually they're extracted and refined and then put back into some sort of medicine so that we get that standardized cannabinoid ratio. So we're starting to see people being exposed to much larger doses of cannabinoids than they would have had through normal mechanisms. Currently, they're not commercially available in Australia. There's this idea of the entourage effect, where it's the combination of cannabinoids and other phytochemicals that are available in cannabis that work together to give its clinical effects. It's been difficult to quantify because of that idea that, different plants will have different things, so how much of the entourage effect is important. And also it's really hard to quantify because a lot of the chemicals are not unique to cannabis. They're found in rosemary, they're found in lemons, they're found in other things that we eat. So how much of it's because it was present in the plant and how much of it was different. And again, these other terpenoids, the limonene, all of these are very different proportions in different products. There are very few studies examining the differences between plant-derived cannabis medicines and synthetic cannabis medicines. It's usually synthetic cannabis medicine or comparator, or plant-derived cannabis medicine or comparator. People are starting to do more studies looking at, if we have a plant-derived full-spectrum extract type thing where you've got the trace cannabinoids in it versus pure, but they're not mature. Everything available in Australia is pretty much plant-derived. Nabiximols is plant-derived. It's got trace other cannabinoids in it. All the goods coming in under TGO 93 have trace cannabinoids and everything else. So there's traces of other things in all of these drugs. So when we talk around where are we seeing the real interest at the moment, on my list here isn't pediatric epilepsy, and we'll certainly talk about epilepsy, but one of the things is with pediatric epilepsy, it's being used in really refractory kids. And so generally our advice would be, just like any other significantly refractory condition, you probably don't want to take responsibility for prescribing an experimental drug to a patient with really refractory disease unless you're working with that other specialists in that particular either symptom or disease. And that's just for everybody. We don't expect an adult gastroenterologist to be prescribing for a pain medicine problem. We don't expect an intensivist to be prescribing for anorexia. We just expect people to be thinking really carefully about what they're doing and what's within my normal scope of practice. Where do I work with my colleagues, and to try and make sure that the patient's got coordinated care, so that we don't wind up with this problem of either a doctor feeling compelled to prescribe when they're not comfortable to do it without support from their colleagues, or a patient sort of being led up the garden path a little bit, I think, with an idea that something might help when it might not. So the TGA guidance documents, so as I said earlier, the Therapeutic Goods Administration, along with a whole lot of groups, they involved RACGP as well as consumer groups, as well as groups with special interests in the various conditions, to develop some guidance for the use of cannabis medicines. What it really is an evidence review. It doesn't help you a lot if you want to know what dose I should use of what medicine for what condition, but it does give you a broad understanding of what's the state of the evidence from systematic reviews for the common conditions that people are interested in prescribing for. So one of the big conditions, of course, is palliative care. And the messages that come through is that it's adjunctive to standard palliative care management. You don't abandon your normal tools for looking after your palliative care patients to use a cannabis medicine. You think about, where could this cannabis medicine fit? What symptom am I trying to target? And then you choose your cannabis medicine for that. It's really probably not going to modify the course of a patient's disease, although sometimes, patients feel that it's made a huge difference to their quality of life, and so they feel like things have happened. And one of the things that's really difficult in this space is when we do the clinical trials, such as the one I talked about, these large clinical trials with the Sativex for chronic cancer pain, we get might help a bit, is really different to patients' personal stories about, I took it and it was the best thing. I could sleep for the first time. I felt so much better. So we're still trying to understand what it is that the patients are responding to. Is it the placebo effect where, the harder it is to get access to a treatment, the more likely we are to feel that it works? Is it the fact that you have that dissociative experience where the pain's still there, but actually, doc, I don't care about it? That's what one of my palliative care colleagues has said when she talked to her patients using it. The pain's still there, but I just don't care about it while I'm taking cannabis, which, is a relief for that patient. And so what we often found when we were trying to work out what to do the clinical trials was that the studies were often missing the primary endpoints, but sort of consistently what was being found was this improved quality of life, and they seem to be fairly well tolerated. So we've got this clinical trial underway in New South Wales looking at appetite stimulation, and there'll be a new trial announced soon that's just about trying to pitch some of that quality of life thing, and it's more of an access trial that'll be available to patients across New South Wales. We're running that with the new Cannabis Research Institute up in Newcastle, and they've got a number of GPs, palliative care providers, so that we're trying to design that trial so it's as accessible as possible, and there'll be more information about that once we've got that all solidified and the ethics committee has approved it and all those things.
And these guidelines are very easily found if you just Google the title.
They are, absolutely. So what did they find when they actually looked at it? And this is this problem that I'm talking about where there was no differences between cannabinoids and placebo for improving caloric intake. So we would really expect that to have worked. You know, everyone knows somebody who did something at uni and got the munchies. But when we see it in clinical trials, we're not seeing it. We're not seeing that huge improvement in appetite. We're not seeing a huge difference in nausea and vomiting. We're not seeing a big difference in pain. We're seeing a trend towards it helping, but we're not seeing a statistically significant effect. But we do know it's fairly well tolerated, and we're not seeing a huge number of adverse events. So if it's something that you've tried your standard manoeuvres in palliative care and you've got a patient who would like to try it, then perhaps that's what you're taking into account. We've also seen some interest in dementia, and it's not helped by the headlines like cannabis will help reverse dementia. I think a lot of us have got a family member with dementia or know a close friend or it's a very common condition, and it's a very distressing condition for family and for patient and for everyone. And unfortunately, we know with dementia that pharmaceutical interventions are not ideal, and it's the behavioural management and everything. And so we've got to take that all into account before anyone thinks about using a cannabinoid for dementia. There have been 2 trials done overseas where they looked at the dronabinol, which is that synthetic THC product, versus placebo and Alzheimer's type dementia. In the trials, they had small numbers. They had difficulty recruiting to them. That's something that we are seeing commonly with cannabis trials. They often fail because people don't want to be recruited into them, either because they're already using something and they don't want to move on to it, or there's a stigma about using cannabis as a medicine. And what we see is that for dronabinol, there was some weight gain. And in using dronabinol, we had negative effect decrease in therapy phases, and we saw a greater reduction in patients receiving cannabinoids. So it could help, because we know that with dementia, we can see, a problem with weight loss. And so, something that stimulates appetite, not necessarily a bad thing, something that might help with anxiety and depression. But again, it's very experimental. We're not going to reverse dementia at the moment, again, unless you're a mouse. Really good if you're a mouse. I can't help wishing I was a mouse. But at the moment, we haven't got the evidence in human studies. So moving on to epilepsy. And so we've had that historical use of cannabis tincture for seizure control. And to be honest, it largely fell out of use because we got better drugs. And those better drugs were things like bromide and phenobarbital, which most of us would not think of using in a human anymore. However, we do know that we've got kids who are still fitting after lots of exposure to lots of different anti-epileptic drugs. And so we've got clinical trials currently focusing on high-dose cannabidiol in treatment-resistant epilepsy syndromes. If you talk to the paediatric neurologist, they'll talk to you about significant drug-drug interactions and the fact that this needs to be monitored really closely. They've seen liver function tests get very, very deranged. We've already talked about the fact that it's already a very high cost thing. And so if you do have paediatric patients who are interested, usually they're refractory, they've failed at least 5 drug therapies. They're probably under the care of our paediatric neurologists, but all paediatric neurologists in New South Wales are actually authorised prescribers. for the cannabidiol, and all children who meet those particularly refractory criteria are actually eligible to go into our pool to receive compassionate access. And at the moment, that's being triaged on clinical necessity by a team of paediatric neurologists who've set up that criteria.
And so do they get the cannabinoids through the hospital?
Yeah, so they're being supplied directly from the 4 centres that have got paediatric neurologists operating from them. So if we do look at epilepsy patients, and of course some of these studies are not just being done in under 18s, they're actually being done in people, to 25 and 30 with some of these complex epilepsy syndromes such as Lennox-Gastaut and Dravet syndrome. I'm not professing to be an expert in any of these particular syndromes, but they are the very refractory things. And so it favours CBD as far as working. It can help in some people achieve a 50% reduction in seizures. But what we don't have is the evidence that you'd sort of see in the media where you would expect that every child being administered CBD would suddenly stop fitting for life. We also don't have a lot of evidence that it's useful as a rescue medication. So again, you'll see some of the parents in the media sort of, putting out a dab of cannabis and rubbing it in the cheek. There's not a lot of evidence that it actually works as a rescue medication, and I'd probably prefer any relative of mine to be given an urgent benzodiazepine. I think that's still the treatment of choice, rather than have cannabis rubbed in their cheek. But it's an interesting drug. There are other cannabinoids that are being investigated for anti-epileptic effects, but we're not there yet. Now, here we're moving on to chronic pain. And this is the really challenging area, I think, for everybody, because again, we've got a cluster of symptoms that at this point we know drugs are not the answer for, but at the end of the day, drugs are sometimes the only answer we've got. We've got this problem of a lot of anecdote in the community about how it will really change somebody's pain. And what we really want to do is help people understand where the actual evidence is on chronic pain. And again, it's being studied in clinical trials, some of which are quite large. But the real thing to emphasise here again is that drugs are not the core component of therapy. Patient education is really important, particularly when they're expecting that the drug is going to do wonders for them. And the real take-home message is that there's this need for larger trials of sufficient quality, size and duration to help us understand what role, if any, the cannabinoids have in chronic pain. So when we look at these in clinical trials, the review evidence suggested that to actually get an outcome, we're going to have to treat somewhere between 22 and 26 generic chronic pain patients to get one to have some benefit. So if we have a look at our therapeutic guidelines for analgesia, they'll usually say around an NNT of about 7 to 8 is probably about where we want to be at for chronic pain. So we normally wouldn't pick up our prescription pad for this drug. We also know that from other studies, it's not in this guidance, but it's been discussed by the authors of the guidance, that the number needed to harm, if we treat, we can get that at about 7 to 9. So we've got a terrible number needed to treat to number needed to harm ratio. We do see with people with MS-related neuropathic pain that they seem to get a better effect from it. We see a non-statistically significant increase in the proportion of pains who achieve a 30% reduction in pain intensity. And for non-MS related neuropathic pain, we see a 50% reduction in pain and a reduction in pain scores compared with patients taking a placebo. But when we show these to our colleagues in our Faculty of Pain Medicine, they're not very excited about this. And one of the things they're concerned about is at the moment a lot of people do actually self-medicate with chronic pain. And if we look at a study that's taking place in Australia at the moment and has been published, it's called the Point Study. And this is actually looking at people who are using pharmaceutical opiates. And what's happening, they've gone and had a look at these people. So it's over 1,500 people who've been prescribed opiates for chronic non-cancer pain. And so they had a look on cannabis use, the cannabis use disorder that could be diagnosed, and cannabis use for pain. So out of those 1,500 people, 16% had used cannabis for pain relief, including 6% in the past month. 25% reported that they'd use it for pain relief if they had access. And the really interesting thing is it's a younger group who report a greater pain severity, they get a greater interference from, and they don't cope with their pain as well, and they have more days out of role in the past year. And that's actually something that we're seeing reflected in Canada as well. They looked at 1,000 people coming through the doors of one of their large rheumatology clinics and looked at who was using cannabis for medical purposes, as they have it in Canada, versus their other people. And again, they were younger, they were poorer, they had less coping with similar objective measurements of disease. And so one of the questions is, are we actually seeing cannabis use because people are having trouble negotiating a potentially expensive and difficult to navigate healthcare system, and so people feel that by self-medicating, they're actually doing themselves some good. But having said that, we don't usually recommend people go home and drink alcohol for their pain either. So we do know that it's being used for pain relief in Australia at the moment, with a lot of people self-medicating. So it's a difficult question for GPs, because one of the questions is, well, if my patient's self-medicating, wouldn't it be better to put them on a legal standardised product? But the problem is we still don't know whether that's an appropriate thing to do. We don't know if that's going to stop them using other cannabis sources. We don't know what to prescribe them. There's a whole lot of thorns in that particular argument that we haven't quite got to the end of that discussion. So I think it's not an unreasonable question, am I doing a harm minimisation gesture? But the problem is we may actually just be prolonging somebody's difficulty with rehabilitating from their chronic pain syndrome. So it's a difficult thing.
And they're much more likely to be driving.
And so, there's all those harms in coming into, contact with the criminal justice system, or losing your licence and all of those things. So better off possibly recommending other therapies as best we can. For multiple sclerosis, it's best studied. We've got a registered medicine, and this is what people are used in. For other cannabinoids or other complexes, we've got limitations because we don't have quality evidence for those other cannabinoids being used. We don't have a lot of evidence around disease activity or disability progression, although there's some theoretical immunomodulatory effect, and some of the large registry studies overseas are starting to monitor for, are we getting better outcomes for people, if they're using baclofen versus nabiximols. But we don't actually also, one of the problems is often it's not baclofen plus nabiximols versus baclofen, it's often nabiximols versus nothing. And so we actually don't know how well nabiximols goes, for example, against some of our current standard treatments. So that makes it complex as well. When we talk about chemotherapy-induced nausea and vomiting, the general guidance from the document is high THC medicinal cannabis products can sometimes be effective for nausea and vomiting, but we've had a lot of revolutionary treatments since the clinical trials were being done using dronabinol. And, they include, the advent of 5-HT3 antagonists and the newer things like the NK1 inhibitor, aprepitant and so on, those ones. And even more recently, olanzapine has been shown in a large RCT to have a significant impact in chemo-induced nausea and vomiting. And so we're actually having trouble recruiting patients into our CINV trial, because actually we're doing a much better job of controlling chemotherapy-induced nausea and vomiting even than what we were doing 3 years ago, which is really, such a change, because there are some people who don't tolerate the 5-HT. They can't tolerate the old drugs, like, they get the terrible dystonias and the akathisias. So, there are a group of people who actually are a bit stranded for antiemetic therapy. But for general nausea and vomiting, generally you've got to be really careful before you'd start recommending a cannabinoid. But for chemo-induced nausea and vomiting, we've actually got a clinical trial available in a lot of our centres at the moment. It's using a THC and cannabidiol capsule that's being manufactured by one of those Canadian companies who've got GMP certification. It's at all of these centres around New South Wales. And so if you do have a patient that's particularly interested, it's probably worth talking to them about getting involved in the clinical trial. The trial methodology is they're exposed to cannabinoid or placebo in cycle 1, and then switch, and then choice of therapy for cycle 3. So everyone gets a cannabinoid at some point, and then it's unmasked at the end. And if the patient's actually responded to the cannabinoid, they're then eligible for ongoing treatment at no cost with those cannabinoids. So in helping us generate the evidence, which is what we really want to do, we want to see, what place these have in therapy, so that as doctors, when we're actually asked to pick up a pen and prescribe, what do we do? So moving on to what they're doing in Canada. So Canada's often held up as the model for care. One of the things to recognise in Canada is, in Canada, doctors actually don't prescribe cannabis medicines. They can make a recommendation that a patient can access cannabis. But as part of that recommendation, they don't actually specify which cannabinoids are being used, and the patient can take that recommendation for 1 gram of cannabis per day, for example, and take it to the local dispensary, where the cannabis guru there will inform them what will work for them best. So the doctor doesn't have a lot of control over what their patient actually receives. So it's a very different system of accessing cannabis. And in fact, the Canadian, I think it's the Society of Physicians and Surgeons in Canada, have said, now that we're going to decriminalise cannabis, we want that whole regime gone. But there's a different argument for a different day. So basically, though, what they've done in Canada is where the physicians have been, particularly family physicians, are being asked. This is the flowchart that the family physicians in Canada have suggested that people have a look at. And this is trying to put things into perspective as to what a general practitioner, a family physician, might actually want to do. So they're basically saying, is it for neuropathic pain, palliative pain, CINV or spasticity, or spinal cord spasticity? Because, if you've got spasticity from one neurological disease, you're probably going to get similar effects for a different neurological disease with the same outcome of spasticity. Let's not get too precious. If it's not for those things, as a family physician, you'd recommend against use. Now, that's not saying a specialist. One of the things they discuss in this article that I've listed there, and it's freely available, you don't have to be a subscriber, is, why as a family physician you might not want to be prescribing for refractory paediatric epilepsy, for example. And so that's why it's not addressed in this flow chart. These are things that they say, as a GP, as a family physician, you may be confronted with. And so, they're sort of talking about, for people with neuropathic pain, have you done more than 3 medications? Have you done more than 3 standard interventions for that patient? For the palliative pain, have they had 2 different interventions? Because, lower standard, different pain mechanisms, again, for all the different ways people get pain and discomfort from cancer. And again, are they refractory to standard therapies for these things? Then maybe try one of the medical cannabinoids as an adjunctive therapy. And so in Australia, we've got more control over the cannabinoids that we use here. We don't have dronabinol, for example, available here, but we do have TGO 93 regulated THC products. They generally say don't let your patient go off and do it themselves because particularly smoke, because of the high risk of bias in available studies, and we still don't know what's going to happen if people are exposed to a lot of these at much higher doses than we're used to there. But always talk to your patient. That's the really important thing about not shutting down the conversation. It's about talking it through with your patient. One of the questions I've just seen coming up was, can we monitor blood levels with and the answer is we've just resourced the University of Newcastle Centre to actually do some of that work with us, and that's around being able to get some blood levels so that if a person has started at what they thought was a low dose of THC and the patient has a very abnormal reaction, is seeing fairies or fitting or doing something really abnormal and you want to know what's happened. I understand if you get a serum tube collected and send it to John Hunter Hospital, you can request your normal pathology collected and divert it to John Hunter Hospital to ACRE for cannabinoid studies. That can be done. But as I say, we still don't understand a lot about what a blood level versus a symptom means. But it certainly can be done, but it's not being routinely done at the moment. But considering how little we know about how these medicines are absorbed and how they're acting and at what doses they're acting and at what blood levels they're acting, we're certainly encouraging, as part of that big palliative care study I was talking about, we're sort of saying 24 hours after studying, we'd like to get a tube of blood out of everyone, please, so we can see how very different people are. We've also got a laundry list of things that people are also interested in and that you'll see in the media as something that it's really important that we have access to cannabis medicines to be able to fix. So PTSD is a big one. We've seen the things that I'm showing here are things that people have studied. We've seen studies for THC, cannabidiol and nabilone. In the RCT using nabilone, we saw some decrease in nightmares for PTSD, but there was a high risk of bias. One of the hard parts about doing research with cannabis medicines is people usually know when they've got THC on board. I'm sure that'll come as a surprise to everyone, but it's really, really hard to blind people to whether they've received THC or not, because a lot of people do actually get those side effects or effects, again, depending on your personal predilection. For anxiety, people are interested in studying cannabidiol and nabilone. Basically, at the moment, we've seen a person given a single dose of cannabidiol and seen whether they can be made as anxious as when they haven't. We haven't got long-term exposure to cannabidiol for anxiety. For depression, we haven't got much human evidence. For Tourette's, we've seen some case reports in the literature. There's been a use of THC, which has seen some tic reduction, again, uncontrolled studies, high risk of bias. For Parkinson's disease, there's a lot of interest, and anyone who's watched YouTube would think that it was going to fix tremor and fix micrographia and fix everything. There might be some improvement with dyskinesia with cannabidiol, but we don't have really good hang your hat on it evidence yet. For Huntington's disease, there was some small benefit from nabilone. People using cannabidiol and nabiximols, we didn't see an effect. For psychosis, people have used cannabidiol, and we're likely to see in the future much, much better studies around schizophrenia and psychosis, because cannabidiol seems to be a really interesting antipsychotic, but we're not there yet. We've got to use our standard treatments at the moment. Moving on to the slightly more curing cancer. Anyone who wants to Google, can cannabis cure cancer, they'll find out that the answer is, of course, it can. There are thousands of studies. We as the government are deliberately hiding the cure for cancer because we're in bed with Big Pharma. And I only wish that was true. But unfortunately, we seem to be there are some really interesting results of cannabinoids because they can promote angiogenesis, they can inhibit and promote mitosis. So some of them are likely to be pro-mutagenic, some of them are likely to be anti-mutagenic. And as I have said to a number of disappointed people, I can cure cancer in a petri dish. It just involves bleach, and I'm sure you wouldn't like me to advise you to drink bleach. So we just don't know. What's really interesting, though, is that they did some interesting mouse models using cannabidiol in a model of glioblastoma multiforme. And what they found was if they gave the mouse just cannabidiol, it didn't work. If they gave it temozolazide, it kind of worked. And then when they gave it cannabidiol and the temozolazide together, the effect was much better. So they've moved that on into a human study, which for glioblastoma multiforme, it might work synergistically with temozolazide, but it's not like we've got live studies, lots of evidence. And then we then wind up with all those problems of it's a rare disease. How do we generate good evidence in rare diseases, which I'm sure we can all have a good conversation about another day. Autism is something that parents are often really interested in, and there's a study underway in Israel, but it's certainly too early to be encouraging people to be taking it up as a medication. One of the things that, is potentially as I said, cannabidiol can be sedative. And so if you've got a disruptive small child that you give a large dose of sedative to, they become a less disruptive small child. And so we don't know how much of it is that and how much of it is actual behavioural modification. So that meets the same for in ADHD. They tried using nabiximols and we had a non-significant trend to improvement in symptoms. So they're really interesting things, but we're not there yet. Inflammatory bowel disease is one of the really interesting areas where Israel did a randomised control trial, and they've also they did a big retrospective trial of people smoking a particular blend of cannabidiol and THC, and then they sort of said, well, that's actually probably not how we're going to be delivering this treatment to people with inflammatory bowel disease in the future. So we do need to do randomised controlled trials, and so I think there's that underway in Israel, and there's certainly a lot of interest in it because it's a really disabling thing, and you'll have seen it in the media here of families who are using it. Fibromyalgia, one of the things that people are suggesting is that fibromyalgia and irritable bowel syndrome and any other disease that we're not particularly good at characterising the pathophysiology of are, of course, because of an endocannabinoid deficiency. So how do you fix that? You give somebody cannabinoid. So there's a lot of interest in the people that we have trouble giving a diagnosis to, people who are feeling abandoned, people who a doctor has said there's nothing more I can do. And they're searching for something. And here we've got this really interesting group of molecules that can do really interesting things. And who can blame a patient for wanting to hang their hat on that? I mean, it's a really normal human reaction, especially if we as doctors don't have much more to add. But for fibromyalgia, they've looked at THC. The TGA guidance suggests it's not robust enough for comment. There's been a study looking at dronabinol, which is that synthetic THC versus amitriptyline. It was as good as amitriptyline. We know a lot more about amitriptyline, and it's very easily available. So if you're going to treat it, I wouldn't suggest that we went straight to THC. But again, some people don't tolerate things.
So Jan, just a few questions that have come off.
Absolutely.
So one of the questions was, can you become addicted to the medicinal cannabinoids?
So as far as THC goes, we know that with long-term use, about 10% of people will develop some form of dependence. As far as if you stop it abruptly, do you have those physiological problems? People might not feel great, but it's not like it's highly dangerous to stop suddenly.
And one of the other questions is, if someone's predisposed to psychotic problems, should they be getting cannabinoids?
Well, they shouldn't be getting THC, that much is certain. So basically, there's a number of contraindications to any of these medications, and they're the standard for THC in particular: personal history of psychosis, personal history of intolerance of the drug, we'd even go as far as to say family history of psychosis. So if you've got a strong family history of schizophrenia, because there's some genetic component to it, we'd probably say don't go mucking around with THC if you can help it. We'd also suggest for developing brains, probably not for under 25s preferentially. Now, there's debate and, about that, but generally developing brain plus psychoactive substance, not our best thing to do. So it's usually recognised as a contraindication. Now, as I mentioned, cannabidiol is actually being explored for its antipsychotic effects. So it may be that in 10 years' time we'll have a very different conversation about the place of cannabinoids in psychiatric disease. But I reckon we'll be having that conversation, in increments over the next 10 years.
So, Jan, can you whet our appetite for the second part of this presentation, please?
So, look, what I think we've talked about tonight is the evidence. And one of the questions is, why is New South Wales Health investing so much time in an area for which we've got such equivocal evidence? Why is the government going out and spending all this time, almost promoting the use of these medicines? And I think what we're really interested in doing with this is trying to help GPs have really good conversations with their patients about these, right? Because I think it's one of these things that if we don't engage, patients will go away and try and manage it themselves. And so I think that's really important. And so in our next one, we'll be talking about the prescribing processes. We'll be talking about some of the reasons why controlled drugs are controlled drugs. I know everyone usually knows it, but we've had this really interesting constellation with the cannabinoids because we know in general practice use of special access scheme and authorised prescriber is pretty rare. I think there might have been some use of authorised prescriber early on in the piece for some of the medical abortion type drugs, but it hasn't been a common thing in general practice to be using unregistered medicines, and that's because usually we'd like to have a lot of information before we do use medicines. And again, the use of the highly controlled drugs like the psychostimulants, again, are usually the province of paediatricians or psychiatrists or respiratory physicians, not something that GPs have often had to fill out the forms with. So if we can help navigate the processes, that's something that will be helpful in the very few, in the times when you do have the patient that I know what the evidence is, I know how much information I've got, and on the balance, I think this would be a good thing to do. What do I do next? And so one of the things that we can do in the meantime between now and the next webinar is we've invested money in putting together a Cannabis Medicines advisory service. It's available 9 till 5, Monday to Friday. They're there to help. If you want to know what the evidence is for use in a condition, they can help you with it. If it's a weird and wonderful that the TGA haven't done, they can go away and do a literature search and come back to you and help you with it. They can tell you about the different cannabinoids that are available. They can help you with the paperwork. They can tell you which form you're going to need to fill in. So I'd really encourage people if they've got questions or are super excited between now and the next couple of weeks, this is what I'd suggest is your first stop. Call the service. They're there to help. We've got drug information pharmacists there, and we've got a clinical pharmacologist there. So they're there. They're experts in medicines, and they're there to help. And they can also tap into that huge network. And they're located in Newcastle and Hunter, New England, so they understand the issues that rural GPs also have in accessing specialist services. So that's what we're there for.
I'd like to just quickly go over what our learning outcomes were. I'd like to hope that we have been able to demonstrate the difference between medicinal cannabis and illicit or black market cannabis. We've briefly spoken about how cannabis works in the body. We've looked at the cannabis medicines that are available at the moment in Australia, and we've also looked at a range of the existing evidence for where cannabinoids may be useful. Part of this discussion tonight is to help us as GPs to have these discussions with our patients. Whether we like it or not, there will be more patients coming to see us and asking about whether or not this is something that will be useful for them. So once again, thank you very much for your attention tonight.
That's great. Thank you, Harry and Jan, for joining us tonight and presenting this webinar. Thank you again, everyone, for joining us tonight, and enjoy the rest of your evening.